Place, because we all know that once you start working in palliative care, you see a lot of non-cancer patients, a lot of non-cancer pain, and sometimes the WHO step ladder or the guidelines may not work as same as in cancer pain. So we decided that this is a very important topic to be included in the refresher course. So today we'll be talking more about pain management in non-cancer illnesses. As every time, we have two faculty members for today's session. One is Dr. Vineetha. Dr. Vineetha is she is a consultant in pain medicine at Kim's Health, which is a corporate hospital in Trivandrum, and she's also a consultant with Pallium India. She's she is trained in palliative care, has been working with us for some time, and then she did her postdoctoral fellowship in pain medicine from Lucknow and intervention pain management from Kolkata. So she still continues with us in a very different role than before. Thank you, Dr. Vineetha, for being a part of this program. Welcome you. And the second faculty we have, he'll be joining us soon, Dr. Ajeeth. Dr. Ajeeth is a consultant at the Imperial College Hospital Healthcare at the NHS Trust, London. Dr. Ajeeth has done his fellowship training in interventional pain management from UK. He's also a faculty of pain medicine at Royal College of Anaesthetists in UK. And he has special interest in intervention, spine pain, and minimally invasive techniques to diagnose and manage spinal pain conditions. So Dr. Ajeeth, both of them were also part of the last program. Welcome, Dr. Ajeeth. If he has joined, we'll be joining soon, I think. We'll start with Dr. Vineetha and then we'll move on to Dr. Ajeeth's presentation. Over to you, Vineetha.
Yeah, good evening, Sridevi. Good evening, everyone. So, shall I share my screen?
Yes, please.
Yeah. Is my slide visible?
Yes, ma'am. In presentation view, yes, perfect. Good to go, ma'am.
Okay. And I'm audible also.
Yes, you are.
Yes, very clear.
Yeah. So, good evening, everyone. So, I thank Sridevi and Pallium India for giving me this opportunity to take a class on this very important topic, which is often neglected in many of the palliative care fellowships, that non-cancer chronic pain. And I don't know how many of you get to see non-cancer chronic pain patients in your practice. Those who are seeing can please raise your hand so that I'll get an idea how many of you are seeing such patients. You can put that in the chat box. And I know about Pallium India because Pallium India is kind of a referral center for pain in Kerala. So we get a lot of non-cancer chronic pain patients in Pallium India. And in where I'm working, that is Kim's Hospital, Trivandrum, there also, because we two doctors are there in the pain team. So I have a colleague looking after the palliative part. So my work, 70 to 80% of my work these days is in non-cancer chronic pain. So I see a lot of non-cancer chronic pain patients in my practice, and I know how challenging it is. So we'll discuss that. So basically, this topic has been divided into two sessions. The first one is just the introduction part, which I am taking. And I can say that is a easier part because you all are already, experts in pain management. You are all practicing pain and palliative care. So you all know the basics of pain management. So I'll be just rushing through the basics and just, giving you that message, what is different in non-cancer chronic pain in that approach. So nothing much that you don't know. I'll be just reminding you of the certain facts about non-cancer chronic pain. And in the second session, Dr. Ajeeth will speak about the evaluation and management of non-cancer chronic pain. So moving on. Slide is not changing, just a minute.
Maybe you can just enable editing. If not done stop sharing, and then in your PPT just enable editing. Sometimes that will be a problem.
But sometimes my computer is also a bit slow. Let's see. I don't know why it is. I have to stop sharing and do the enable editing.
Yeah, in your PPT, you've not done that before. Sometimes it just don't move.
Okay.
Now just check your PPT in the top. You have enabled editing.
Okay.
If it is not showing anything, you might have already enabled. But
Just a minute. Actually, I think this got stuck.
okay. You have the presentation sent to the team so that maybe they can.
No, actually, but this doesn't happen usually. Just a minute.
Yeah, sure. No problem. So it is not really surprising to see so many answers. Yes, most of us see a lot of non-cancer pain. So that makes the session so relevant also. Like as Vineetha was telling, we also see a lot of non-cancer pain, and then we sometimes get stuck with the management. You can't really completely follow the ladder all the time. You might need to think differently, and sometimes most of the times when we are stuck, we call Dr. Vineetha to pitch in and give her advice how to go ahead with that sometimes. So I'm glad to know that everyone is on the same page, that you all face the same problem that we all face here in Kerala.
Topic. Sorry for the delay. Sorry for the delay because it was unexpected. Okay. So let's move on to the introduction of this non-cancer chronic pain. So as I said in the beginning, I'll be taking just the introduction part, and Ajeeth sir will be dealing with the evaluation and management. So a recent prevalence study, it found that around 20% of the Indian adults suffer from the chronic pain. I'm talking about chronic non-cancer pain. And if you look at the cancer survivors, because most of you will be dealing with cancer patients and cancer survivors. So if you look at the prevalence, it is almost double than that the normal population, 30.8% in cancer survivors versus 15.7% in the normal population. So that itself says how important is this topic of non-cancer chronic pain for all of us. Now, I said that the main agenda behind my class is actually to identify the challenges. What is different from dealing with the cancer pain and a non-cancer pain patient? So see this case scenario, a 60-year-old male patient, known case of a CA pancreas on treatment. So he reports severe pain. The pain was earlier managed on weak opioids, but now he reports severe pain uncontrolled on weak opioids, and he is extremely anxious about the pain. He is unable to eat, sleep, or do any work. At the same time, we have another patient with us. The patient does not look like a 60-year-old, but he is a 60-year-old patient, and low back pain for the 5 years. He reports severe pain and uncontrolled on weak opioids. He has been already put on Altracid, Tramadol or something, but it is uncontrolled on weak opioids and physio. He is also extremely anxious. He is unable to go for work, and his sleep is also disturbed due to pain. And all the investigations are within normal limits. So even with this pain and palliative care physicians, I have seen we tend to make some mistakes when we are dealing with this non-cancer chronic pain patient. Okay, so what are those mistakes or challenges? So first of all, this patient, a known case of CA pancreas. Here, first of all, the pain generator is obvious. We all know why the patient is having pain, right? Second, for the same matter, the clinicians believe the patient is having pain. Most of the time, we believe that the patient is having severe pain. Then what is the management? We step up to the strong opioids. That's also usually not a problem when we are dealing with cancer population. But do we assess the severity? Even in the cancer population, do we assess the severity and manage pain adequately? That's a question. So the study found out that when the pain is moderate intensity pain, 80% of the cases, the pain relief is inadequate. It is inadequately managed. And in severe cases, in 94.3% cases in severe pain, the patients get inadequate pain relief. So that is the scenario with cancer patients. Then what will be the scenario with our non-cancer chronic pain population? So here in the non-cancer population, the first thing is the pain generator is often not obvious. Sometimes in the MRI, there will be a huge disc compressing on the nerve root. The patient is having a typical radicular pain. So we know, okay, the disc is causing compression. But most of the time, or not most of the time, sometimes what happens is the pain generator is not obvious. We don't know what causes that pain. All the investigations will be normal. So what happens? Clinicians tend to doubt the patient's pain. So in my practice, in such cases, at least I see that 4 out of 10 doctors, they tend to say that the patient is having some functional problems or psychosomatic issues. Because all these chronic pain patients, they will be having anxiety, depression, multiple sides pain over the course of time. So it's very a common practice to label as functional, psychosomatic, etc. And use of strong opioids. In the other case, if the pain is not responding to weak opioids, we step to the titrate up the analgesics to strong opioids. But here, the use of strong opioids is debated, right? And do we assess the severity and manage pain adequately in chronic pain? So this study conducted in many, Asian countries, almost 10 Asian countries, they found that 20% of the patients, they did not receive any analgesic treatment, not adequate, did not receive any analgesic treatment despite having moderate to severe pain. So that is a state of affairs when we come to this non-cancer chronic pain. The clinicians, they don't believe the patient is in pain. The clinicians don't know what to do next. We cannot step up to the strong opioids that easily. Or sometimes they just go up the analgesic ladder. If the patient is not responding to weak opioids, sometimes I think the best, that is a problem. They step up to the strong opioids easily. Then a new set of problems, opioid dependence, addiction, hyperalgesia, all these comes. So to sum up, I can say that the chronic pain is an invisible illness. The pain generator is often not obvious. The patient reports that he is in severe pain, but he may not appear to be, for you, he may not appear to be in severe pain. So it's kind of an invisible illness. And what are the consequences? One is, we tend to say it's all in your head. Second, unnecessary consultations, investigations, imaging. Third, as I said, for some patients, we just step up the analgesic ladder and this leads to opioid abuse. So these are the problems when you are dealing with problems that are separate from cancer pain, when we are dealing with this non-cancer chronic pain patients. So with this introduction, we go on to the definition of pain. So as you all know, the IASP, International Association for Study of Pain, they have revised the definition of pain in 2020. An unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And they have added some notes with this 2020 revised definition. So in short, what do they say? Pain is always a personal experience that is influenced by a lot of other factors, biological, psychological, social factors. Okay, it is a very personal and subjective experience. Each patient, even when they have the same intensity of pain, the pain behavior and the pain perception, everything will vary from patient to patient. Second, pain and nociception are different phenomena. Nociception means an injury is happening and there is transmission and transduction of the pain signals. That is when you call it as nociception. But the perception of pain, that again will be influenced by a lot of factors. So these two are different. Third, through their life experiences, individuals learn the concept of pain. For example, if during a previous injection, you had experienced severe pain, for the next injection, your expectation or your experience is so bad that even if it doesn't hurt, your perception of pain will be that you had severe pain. So your past experiences, your expectations, all these affect the perception of pain. Then a person's report of an experience, but that should be respected. Okay. And although the pain usually serves as an adaptive role, when it becomes chronic, it has got a maladaptive role. It causes deconditioning, not just physical deconditioning, mental deconditioning also. And the sixth and the final one is, the verbal description is only one of the several behaviors to express pain. That if a patient is not able to communicate properly, that verbally that he is having pain, that does not negate the possibility that he is having severe pain, significant pain. So this is actually why I put this photo is this patient, I talked to this patient just 3 days back, not this patient, picture is just a representation, an old lady staying in Tamil Nadu. So during my visit to Pallium, India, I made a teleconsultation with this patient. So this patient was like an 80-year-old lady. So she was telling me she's having severe low back pain for the past, say, 12 years or something. But recently, for the last 1 year, it is very bad pain. And her pain is worst during sitting. But then she's not working in a temple or anything. Her religious belief is that she sits and make garlands, for puja. She has to sit for a long time. And so when I ask her what is the severity of her pain, she says it is very severe, like 8 to 9 out of 10. But she feels that this is, her religious belief is such that God is making her, go through this pain. And if she survives this pain, if she is able to make through this pain, she will get the blessing. And not just her, the whole family will get the blessing. So because of that faith, because of that relief, even though her pain is severe, she manages well, and she doesn't report it as excruciating or I can't manage. She doesn't appear to be in any kind of distress. So that is how your expectations, your experiences, your relief, each per patient, their relief, their faith, the social cultural factors. So all this influence how pain is being perceived and how the pain behavior is. Okay, but from our point of view, we have to believe pain. We have to believe the patient. Pain is what the patient says it hurts, and it is a subjective experience influenced by a lot of other factors. We have to believe our patient. The most important take-home message from this class will be that, because as I said in the beginning, in cancer pain, believing the patient is not a big problem, because we know the patient comes to us with a diagnosis. So we don't usually tend to suspect the patient. We believe our patient. But in non-cancer chronic pain, this is a huge problem. Labeling the patient as functional or psychological is a huge problem. So I will keep repeating that in my class. Even if that is very boring, I'll keep repeating that we have to believe our patient. That is the first step in the management of evaluation and management of non-cancer chronic pain. And we have to treat early and treat well. Why? What is this early and what does that mean by treat well? I'll come to that in the subsequent slides. Now, coming to the classification of pain. So this, I think every one of you know that acute pain is less than 3 months and chronic pain is more than 3 months. And we have, depending on the character of the pain or the pathophysiology, we have nociceptive pain, neuropathic pain, and nociplastic pain. So nociceptive pain is very simple. When there is a tissue injury or disease, when the tissue nociceptors are activated, that result in the nociceptive pain. Neuropathic pain, the newer definition is that any disease or lesion of the nervous system itself. So can somebody tell me what is nociplastic pain? Anybody if knows the definition of what is nociplastic pain, you can unmute and tell.
Ma'am, this is a pain in which it's similar to neuropathic pain in character, but there is not a specific nervous lesion like fibromyalgia or inflammatory bowel syndrome.
It's very good. Actually, here neither we can identify a tissue damage as like in nociceptive pain, nor we can identify a nervous system disease as in the case of neuropathic pain. But the patient is having pain. Why? Due to sensitization, peripheral and central sensitization. So this, or we can say, altered response by the nervous system. So because of that, there is no lesion or disease of the nervous system, but an altered response of the altered function of the nervous system. So this fibromyalgia, irritable bowel syndrome, chronic post-surgical pain, so many pain conditions are grouped under this nociplastic pain. So is it important to identify the nature or the character of pain? Because we should know that neuropathic pain and nociplastic pain, the response to opioids is less. Some studies say that in nociplastic conditions like fibromyalgia, opioids may even worsen the hyperalgesic situation. So I have seen a tendency with young doctors trained in pain and palliative care. What they do is, they actually very well understand the suffering of the patient and they somehow want to help the patient. So what they do is, if the step 1 or step 2 of the analgesic ladder does not work, they step up to step 3. It is because they want to help the patient. And if low dose opioids, maybe due to placebo effect, there will be some response, then they will hike the dose. There may not be much response, but again, the suffering is, very high. So they will go on hiking the dose of opioids. So what we don't understand is, by rule, nociplastic and neuropathic pain, they won't respond to opioids as much as the nociceptive pain. And in certain situations, it may even worsen hyperalgesia. Why? Because in neuropathic pain and nociplastic conditions, the endogenous opioids are dysregulated. You can go through this article which I have given below. The endogenous opioid system is dysregulated. The endogenous opioids are already high and the opioid receptors are downregulated. So there is no point in giving opioids. It may even worsen the situation. So can somebody tell me the opioids for neuropathic pain? If at all you want to use opioids for neuropathic pain, which opioids that you will use? Is it morphine, or what is your choice for neuropathic pain? There is no problem if you are wrong, because I want the class to be interactive. Otherwise, we will all start sleeping within a few minutes.
Amitriptyline. Gabapentin.
No, I'm asking about opioids. I understand neuropathic pain medications, but suppose
It's methadone.
methadone, yes, correct, ma'am. And another one? Any other one?
Tramadol.
Yes, tramadol. One more?
Tramadol.
Pardon?
Tramadol.
Yes, tramadol, tapentadol, methadone, I agree. One more? So the clue is, anything which has got an action other than the mu receptor agonistic action will have more role in the neuropathic pain. Methadone has some NMDA action, as you all know. Tramadol has noradrenaline reuptake inhibition activity. Tramadol, tapentadol, methadone, and one more is there, buprenorphine. Because it is a partial agonist antagonist, buprenorphine also has got a better role in neuropathic pain. So if at all you have to use opioids for neuropathic pain, if at all, then it is better to go for these opioids rather than starting the patient on morphine. Okay. Now, coming to the etiology of non-cancer chronic pain. So this is important because, as I said again in the beginning, in cancer pain, we know why the patient is having pain. But in non-cancer chronic pain, we should all try to identify the pain generator. This word is very, very important. We have to identify why the patient is having pain, identify the pain generator, as well as why it causes pain. What is the etiology? So in non-cancer cases, it can be degenerative, trauma related to the old trauma. Then inflammatory, like ankylosing spondylitis, rheumatoid arthritis, the inflammatory conditions, then genetic and other autoimmune causes. So we should try from our part to identify the pain generator as well as the etiology. So a simple example here is, look at the lumbar spine. No, there are so many structures here. We have the vertebra, we have the disc, we have the facet joints connecting the vertebra, we have the ligaments, muscles, we have the nerves, we have the spinal canal. But when patients come to you with low back pain, and when they explain their symptoms, what do they usually say as the cause of their low back pain? Like when they talk to you, maybe not patients, your relatives, what do they say the cause of low back pain? Most commonly. Anybody?
IVDP.
Yeah. Everyone will say, oh, I recently took an MRI. I had 2-level disc bulges. So that is the cause of my low back pain. So I'm now taking a lot of, restrictions. I won't bend forward. I won't lift weight. I won't even go for walk because I'm having an IVDP disc bulge, and anything I do more, it can cause the disc to bulge. More doctor has advised us, so on like that. But the thing is, the disc herniation, or the compression on the nerve root causing radicular pain, it constitutes only less than 5% of the low back pain. But what happens is 95% of your patients will tell you that disc bulge is the cause of my low back pain, whereas in reality, it contributes only to less than 5% of the low back pain. So if you refer all of your low back pain patients for MRI, thinking that you are dealing with the patient may be having an IVDP, you are actually unnecessarily causing financial burden and a lot of that kind of trauma to the patient. So you should understand what is the commonest cause of back pain in a young patient and an elderly patient. So in young patients, that is less than say 40-45 years, the commonest cause of low back pain is internal disc disruption. It is just that it is not disc herniation. Here the disc will be grossly normal in the MRI, but the internal architecture of the disc is deranged. There may be annular tears. Annulus is the covering of the disc, causing the pain. I won't go to the details of how it is different from radicular pain, but it is definitely not the same as an IVDP or disc herniation. Then commonest cause in elderly is just like our knee osteoarthritis, this facet joints connecting the vertebra, the joint connecting the vertebra will have facet arthropathy, or facet arthropathy is the commonest cause of low back pain in the elderly. So we should know in each case, knee, low back pain, generally we should have an idea, or we should try to find out what is the pain generator and why it causes pain. Unless we make an attempt, we may not be successful every time, but unless we make an attempt like that, we may cause more actually problems to the patient than already what he's having. Okay. Now coming to the physiology and pathophysiology, because you already have an idea about the physiology and pathophysiology, I'll be just touching the basics. I won't be going to the detail. But in all the classes, when I start with physiology, I say that it is very boring to learn the physiology and pathophysiology, but it is important, because unless we know the physiology and pathophysiology, we are dealing with chronic pain patient will be like this. Each person will feel that this is arising from this. Another person will feel this to be completely different. So the pain pathway, in the most simple, representation, schematic representation, it starts from the peripheral nerve. Okay, and the peripheral nerve has the free nerve endings are known as nociceptors. And these nociceptors, when they get activated from a nociceptive stimuli, they transmit the stimuli to the dorsal root ganglion, and from there to the dorsal horn. And from the dorsal horn, the impulse will be transmitted to the brain. So that is the most simplest representation of the pain pathway. So we have the cell bodies, the primary cell bodies, or the primary neurons. We have the cell bodies in the dorsal root ganglion. So they have, okay, I won't go to that details. We'll go to the next section. Now, my question is, if the nociceptive stimuli remained constant, okay, would the pain remain constant? That is the intensity of the pain as well as the area of the pain. Will it remain constant, decrease or increase over time? So what do you think? Anybody can answer.
Increase.
Yeah, it definitely increase. So why do you think that happens? The
Because
stimulus is constant.
sensitization of more recruitment of more receptors and central sensitization.
Okay. So I think so. My job with the physiology and pathophysiology is done if you know that. Sensitization, we see that in any chronic pain, be it cancer pain or non-cancer pain. But it is even more important. Its role is even more important in non-cancer pain because these patients come to us with pain lasting for 5 years, 10 years. So it's very important we understand the modulation of pain. Okay. Now we know that everything starts, the story starts here at transduction, where the noxious stimuli is converted to the pain signal. Then it is transmitted up, that is transmission. Then comes the most important word in pain pathway, the modulation of pain. Because of this modulation, the pain is not constant. There may be increase or decrease. And then finally, the brain is where the perception happens. Okay. Now we all know this spinothalamic tract, the main tract which carries the pain sensation. It starts from the periphery, then spinal cord. It crosses to the opposite side, ascends up and goes to the ventropostural lateral VPL, nucleus of thalamus, and from there it projects into the cortex. And this pathway deals with the discriminative aspect of pain, that is location, where the pain is coming from, what is the nature of pain and the severity of pain. Whereas we have some other pathways, for example, the one shown in the green. The one shown in red is the spinothalamic tract. Okay, the other one is the spinoreticular and the spinolimbic pathways, which deals with the emotions, the autonomic responses, and the modulation of pain. And we have these tracts, the blue pathways. Which one is this one? The descending inhibitory pathways. So this red one is the spinothalamic tract, which deals with the nature, location, severity of pain. These two, the green and the blue, these deal with the modulation of pain. So if we have to target the modulation, these are the pathways where we have to target. So I will show you how. So the modulation of pain can be excitatory modulation, which he clearly told, which is sensitization or inhibitory modulation. So what exactly happens in the event of sensitization? So we have two types of sensitization, peripheral sensitization and central sensitization. So I won't be going to the details of this, but one word, do you know one word to describe this? What is happening there in the periphery? This is a soup. What is this soup? Anybody knows? What is this soup called? This is inflammatory soup. So whenever there is a tissue injury, this mast cells, neutrophils, they are attracted and they release a lot of inflammatory mediators. And your nerve, the nociceptor, is now exposed to this inflammatory soup. What happens is there is a lower threshold for stimulation, more nociceptors are recruited. For any given stimulus, there will be an increased response, and all these results in what is known as primary hyperalgesia. That is, for any given stimulus, there is an exaggerated, for any given noxious stimuli, there is an exaggerated response. Okay, so we can target here the prostaglandin production. How do we target that? With the help of NSAIDs. Then we can target here the impulse transmission with the help of local anesthetics. That is how we target the peripheral sensitization. What happens in central sensitization, that is beyond the scope of the class to explain everything. But this receptor is actually plays a major role in central sensitization. And what is this? This is an NMDA.
NMDA.
Yeah, NMDA, very good. So how can we target the central sensitization? We can attack the NMDA. We have the NMDA antagonists like ketamine, yes, methadone, all those things. Now we can attack here. What is this? What is this? Any idea? This is voltage
T5.
gated. Yeah.
Fibers.
Yeah, this is voltage gated. This is a presynaptic neuron. Okay. This is a postsynaptic neuron. So this neuron will release the neurotransmitters, and this these transmitters will act on the receptors in the postsynaptic neuron. So this voltage gated calcium channels, calcium enters through these channels and causes the release of neurotransmitters. So if we attack this voltage gated calcium channels, we can prevent the release, we can decrease the release of neurotransmitters. So how we do that? How can we attack this voltage gated calcium channels? Which drug?
Calcium channel blockers.
Which one? Voltage gated calcium channels in the presynaptic neuron. Which one?
Gabapentin.
Yeah, correct.
Gabapentin.
Gabapentinoids. Okay. So that is a role of, that is why pregabalin is one of the FDA approved drugs for fibromyalgia. That is a role of gabapentinoids whenever there is central sensitization. Now where we can attack, the next is here, the impulse transmission. So we can use sodium channel blockers like lignocaine and oxcarbazepine. Next, where we can attack here. So you can see that this COX-2 produces prostaglandins, which act on the receptors in this presynaptic neuron and causes the release of neurotransmitters. So how can we attack that COX-2? NSAIDs. So this is how we attack this central sensitization. Now, so this is the net effect of central sensitization. So projection neurons are the neurons in the dorsal horn of spinal cord. So the result of central sensitization is the increased response of these projection neurons and increases the receptive field of projection neurons and synaptic reorganization of A beta. A beta is a fiber carrying touch. What happens when there is synaptic reorganization? Even touch becomes painful. So all this happens in central sensitization, and the net result is secondary hyperalgesia and allodynia. This is also known as neuroplasticity and wind-up phenomenon. Okay. So this is a net result. So can anybody tell me what is secondary hyperalgesia and allodynia? Primary hyperalgesia, I already told. What is secondary hyperalgesia? So outside the original site of injury. So suppose your original site of injury was in the C6 dermatome. Now, even in the C5 dermatome, there is a noxious stimuli. The patient will have an exaggerated response to that. So that is known as the secondary hyperalgesia, primary hyperalgesia and secondary hyperalgesia. And what is allodynia?
Even a non-noxious stimulus appears to be painful.
Painful. So even touch becomes painful. So all this is a result of the peripheral and central sensitization. And this is inhibitory modulation. So what we need to know is, this is an important structure, PAG, periaqueductal gray, which plays a very important role in this inhibitory modulation. And then we have noradrenaline. Okay, these nerves, they release noradrenaline that act on what? Alpha-2 receptors. So how can we promote, or how can we augment this inhibitory modulation? That is a role of clonidine, like dexmedetomidine alpha-2 receptor agonist, as well as noradrenaline reuptake inhibitors like tramadol and SNRIs. So that is how we target the inhibitory modulation. So I think going out of my time, so I'll just speed up the rest. So just like in an army, we have so many weapons, guns, bullets. What should be our armamentarium? No, we should have the awareness, we should have the attitude, the respect the patient's pain perception, experience, knowledge, and skills. And the most important enemy in front of us when you are dealing with non-cancer chronic pain is sensitization. That is why I told earlier we have to intervene early. Then some differences when we are dealing with the chronic non-cancer pain. So this I have already explained, that we should understand the biopsychosocial model of pain. That is, pain is not just nociception. It is influenced by the socio-cultural and the psychological aspects, which determines the amount of suffering the patient is having. So throughout the assessment and management of chronic pain, we should understand and keep in mind this biopsychosocial model of pain. And we all know the WHO analgesic ladder, and it produces adequate pain relief in 71 to 76% of cancer patients. But what happens in non-cancer pain? The response to opioids is often unpredictable, unsatisfactory, and as I told earlier, it may result in more harm than benefit. So what we have to do is the psychosocial modalities to improve the coping mechanisms, the physical modalities, interventional pain management, all should form major components in chronic pain management rather than just climbing up the analgesic ladder. And we should have a holistic approach to the patient. We have to treat the whole patient and not just the pain. So recently, I had a peripheral vascular disease patient who has been referred from Tamil Nadu, and this patient was on pregabalin 300 milligram per day plus gabapentin around 900 milligram per day and plus tramadol, and the patient was having extreme fatigue, and the patient was having a lot of problems, and his pain was still remaining the same. So we have to respect the patient's pain experience, the pain perception. And while we are titrating in the analgesics or the adjuvants, we have to respect the side effects also. We have to respect the patient's wishes, concerns. We cannot say that if you need me to treat the pain, you have to cooperate with me. You have to take the analgesics or adjuvants as I prescribe. We cannot command like that. We have to treat the patient as a whole, respect the problems, respect their concerns, and then titrate the analgesics accordingly. So we have to move away from the analgesic ladder and move towards this pyramid model for symptom control, where all these are given equal importance: the disease-modifying therapies, pharmacological palliation, surgical and physical procedures, interventions, psychological and nursing interventions. And this is a ladder which is not by WHO, but suggested for the management of non-cancer chronic pain. Here you can see the differences. Step 3 comprises of interventions rather than step 4. Okay, and throughout the ladder, we have to do incorporate the integrative medicine therapy, which includes the physical and psychological modalities, cognitive behavioral therapy, acupuncture, TENS, yoga, and all this physical and psychological modalities. So 2 cases, I'll just, to wind up my session, I'll just go through that in 5 minutes time. The first one is a 66-year-old gentleman with complaints of low back pain for 5 years. It was a spontaneous onset and gradually increased over time. He was having a nociceptive kind of pain, a dull pain, no radiation to lower limbs, no neuropathic features, somewhere around the moderate intensity pain. And he had pain on waking up in the morning with stiffness for a few minutes, standing for some time. He was comfortable with walking actually. No red flags. And this is for the last 5 years. Last 2 years, he's having almost similar intensity pain in the upper back and neck also. And he's quite anxious, frustrated, but he runs a small business and continues to earn for his family. Coming to the treatment history, just 1 month after the onset of pain, he visited a spine specialist who ordered an MRI, which was within normal limits. He was given medications and advised physio. He visited multiple specialists over the last 5 years. 2 more MRIs were taken in the last 2 years, referred to multiple psychiatrists, psychologists. Why? Because he was having multiple sites pain with no correlative findings in the imaging. And the result is that no improvement in pain till date. So can anybody tell me what can be the cause of such pain? Do you actually think this patient is having a psychosomatic problem? Or does anybody have a clue to what this patient is having? What kind of a pain this patient is having?
He might be having any facet joint arthropathy because a
Correct.
60-year-old.
Yes, correct.
So
yes, the commonest cause of back pain in patients more than 60 years is facet arthropathy. For the same reason, imaging is normal. Imaging has no role in diagnosing facet arthropathy. In patients more than 60 years, facet hypertrophy, you will see in all MRI, but imaging has no role in predicting that as the cause for pain. So his pain started in the low back. Then later in the last 2 years, he is having pain in the upper back and neck. Why? because of the altered biomechanics, the altered posture, altered loading in the spine. When there is altered loading in the lumbar spine, after some time problem starts appearing in the dorsal spine and cervical spine also. And then again, due to sensitization. That is why in the last 2 years, he started having pain in the upper back and neck also. And anxiety, frustration. It is quite understandable. 5 years, 3 MRIs, multiple specialists, no diagnosis, no relief. But even then, many specialists considered him to be having a psychiatric problem, a psychosomatic problem, and he has been asked to, he has been shuttled from one psychiatrist to another. So finally, an immunologist referred this patient to the pain clinic. And because for me, I also consider the commonest cause first. So I did a medial branch of dorsal ramus L3, L4, L5 diagnostic block. Patient had excellent relief for low back pain. And for the neck and upper back, I did some, that is a second sitting, not in the same sitting. In the second sitting, I did some myofascial trigger point injections, followed by physiotherapy and stretching exercise. He got good relief. And later, finally, he underwent radiofrequency ablation of the medial branch. And till now, it's 3 months after the procedure, he is having 80% relief. Okay. So that is why I told we should make some attempt to identify the pain generator, even when all the investigations, everything looks normal. And second case, you may be more familiar with this particular patient, 70-year-old, a known case of CA oropharynx. It was locally advanced. He underwent some surgery in another center because this patient came to us 1 year later, including neck dissection. Some surgery was done. He completed radiation chemotherapy. 1 year later, he presented with right-sided neck pain of a gradual onset and gradual worsening. And he had an aching pain with 6 to 8 out of 10 intensity. And occasionally the pain radiates to the head, that is a frontal region, as well as the shoulder. No neuropathic features. And his activity, sleep, everything was affected due to pain. He was extremely anxious also because he thought this to be something to do with the recurrence of cancer. MRI, PET scans were taken, nothing significant. The patient was started on morphine, and because he did not respond to other drugs. The morphine made him dizzy, made him feel more fatigued, but there was no reduction in pain. That was when the patient came to our center. And even then he was thinking this is something to do with the recurrence of CA. That is why they discontinued the treatment there and came to us. So can you tell me, this head and neck cancer patients, after neck dissection, complaining of neck pain, what could have been the cause for this neck pain? After radiation, after neck dissection, any idea?
No, occipital neuralgia, not sure.
So for this patient, actually, when we examined, he had thought once with tenderness and referred pain in the right trapezius muscle. That is, it was actually a case of simple myofascial pain syndrome. Okay. So when trapezius, when there is trigger point, it produces a pattern. Anterior trapezius, it produces a pattern like this. The anterior fibers, there will be neck pain and it radiates to the frontal region. And in the posterior trapezius, the posterior fibers, it produces a pattern like this, the upper trapezius towards the shoulder. So just a representative image, this patient was given because he was in acute severe pain, even not responding to morphine in the first sitting. Otherwise, I don't do any intervention in the first sitting. But this patient was in severe pain. I did a myofascial trigger point injection and sent him for some physiotherapy. He had complete relief in pain and morphine was gradually tapered off. So why you should understand that almost 13% of head and neck cancer patients, they develop myofascial pain syndrome as a consequence of this head and neck cancer treatment, surgery, especially when neck dissection is there, and radiation induced fibrosis, because this causes altered loading of the muscles. So that is the importance. Now, the Declaration of Montreal in October 2010, the International Association of Study of Pain, they put forward this Declaration of Montreal that access to pain management is a fundamental human right. But still, there are so many barriers to pain relief. Most importantly, the attitude towards pain, underestimation of pain, misconceptions about painkillers, underprescription, which leads to unnecessary suffering. And In our hospital where I'm working, the corporate hospital, any problem to the patient, like if there is a fluctuation in the respiratory rate, heart rate, immediately they will announce, the code blue, code RRT. But when somebody is pain, this kind of an urgency, severe pain, this kind of an urgency is not seen. Why? Because nobody dies due to pain. But what the clinicians, they don't understand is that many people die in pain, and even more worse, coming to our non-cancer chronic pain patients, the many people, they live in pain. So this has to be kept in pain when we are dealing with the non-cancer chronic pain patients. So I'll conclude this because I'm already running out of time. Sorry for starting a little bit, there was a delay in starting the presentation also. So sorry for that. So our motto should be to believe the patient, treat early and treat well. So thank you for the patient listening.
Thank you, Dr. Vineetha. I'm just rushing to Dr. Ajeeth because we have a case presentation also to go. Dr. Ajeeth, over to you. Without much delay, we'll take questions in the end, and participants, please type your questions in the chat so that we can take it in the end.
Good evening, everyone. Can you hear me?
Yes, sir. Yes.
Yes. So before we go into the nitty-gritty of how to evaluate pain, let me thank the organizers for inviting me again for this program. And I would also like to thank my classmate and good friend, Dr. Sunil, for again inviting me for this program. So hopefully this would be a talk which is insightful and thought-provoking for you. Okay, so Vineetha has given a very detailed overview of the physiology and the basics of pain. Now, I will give an overview of this talk by discussing few cases, and if time permits, and if Raj Lakshmi permits, I can give a quick overview of the opioid situation in the West. Now, how do we evaluate pain? Unfortunately, we don't have a blood test or a scan which can diagnose the pain. Okay, so as Vineetha said, pain is totally subjective. It is what the patient says it is. You have to believe the patient. It's all in the history. Okay, imagine if there is somebody comes up with a new scan or a blood test wherein you can know the intensity of the pain which the patient is having, the type of the pain, whether it is nociceptive, neuropathic, or say what's the psychosocial factor surrounding the pain. How good it would be. I mean, it will take away a lot of our headache, and probably we'll be out of job. Like some of the radiologists are now finding it that ChatGPT is slowly getting into their job. But I think for now, our job, my job, and maybe Vineetha's job is secure because, as you know, pain is an entirely subjective phenomenon. Now, when you evaluate pain, it has to be a very comprehensive evaluation. Okay, it's not just the physical manifestation of the pain. As Vineetha said, you have to consider the psychosocial factors surrounding the pain. What's the function status of the pain? Is the pain which is, the patient might be having pain, but if he is having a good quality of life despite being in pain, then why do you need to treat the pain? You can as well leave it as it is. Okay? Now, when we evaluate pain, we have to evaluate different types of pain the same patient is having. So we will discuss as we go along. As Vineetha said, there are 3 different types of pain. Now, it's a simple representation of the pain diagram. Okay, and nociceptive pain is a pain which comes from a damage to the receptor. The simple pain which you have when you have a injury, a cut, an inflammation, infection. Okay, this is a day-to-day pain, good pain, which goes away after the pain is resolved. Sorry, after the injury is gone, and it doesn't bother you after that. It's a good adaptive pain which every animal would have. Okay. Next is neuropathic pain, pain from nerve damage. It's not a good pain. It is always pathological. You have to treat it. Okay. And the nociplastic pain is the one which has all this central sensitization element attached to it. Now, you can have your own approaches to managing the pain. Okay. But this is my approach. Okay. This is what I teach my trainees. So this is a simple step-by-step approach. When you are faced with patients, say 30 patients in a day, it is better to have an organized algorithm in your mind. Okay, you might have very short time to evaluate a patient. So the algorithm which I do is every patient, first you have to rule out red flags. And the second thing is, if there is no red flags, go on to make sure there is no element of central sensitization. What it means is yellow flags, basically. We'll come to yellow flags in a moment. Okay, things like depression, anxiety, all those anxiety surrounding the pain and all those. And if you rule out that, then go on to what exactly is the nature of the pain. Is it a nociceptive pain? Is it a neuropathic pain or nociplastic pain? If it is nociceptive pain, it can be somatic, okay, coming from the somatic structures like say muscle, ligament, joints, all those things. Or is it visceral? It is coming from abdomen, heart, all those things, okay? And neuropathic and nociplastic, okay? Now let's discuss case number 1. Now, this is a 62-year-old male. He's a government servant. He comes with sudden onset of low back pain after a long bike ride, okay? And he's got this stabbing pain over a localized area in the upper lumbar area, which worsens with minimal movements. But the pain doesn't radiate into the legs or arms. There's no sensory symptoms, no bowel or bladder symptoms, which signifies that there is no central cord compression. There is no systemic features. Then he went for Ayurvedic treatment. Pain then got worse. He's not able to sleep now. He has no similar history in the past, no significant chronic pain problem. He's otherwise fit and well apart from hypertension and diabetes. And this persisted despite 2 courses of painkillers. Okay. And on examination, he's fully conscious, no other abnormalities. Everything is normal, basically. Spine movements are restricted. He's kind of very sensitive to any movements. So what next? Can somebody, I mean, everyone can put it in the chat box. What would you do if this patient comes to you? Any answers? But what is the answer? What would you go for? The option 1, option 2, option 3, option 4, or option 5? Okay, I'm seeing the trend now. Okay, so all of you are very conservative doctors. Okay, when I do this talk in other places, I always get an answer 4 or 5, but answer is actually MRI within 1 week. Why? Because what we are dealing is what's called the red flag. This patient has got a red flag. You can't expect the patient to have physiotherapy or paracetamol and leave them aside. Because this is red flag we are looking at. You have to be up on your sleeve. This is something which you have to be doing something emergent. I mean, this is not a simple thing we are dealing about. And this is what this MRI looks like. There's a compression fracture at L2, another compression fracture somewhere in upper thoracic area. And this is what the transverse section. So this turned out to be compression fractures secondary to TB. Okay. Now, what are the red flags for back pain? So you have to be aware, red flags are extremely rare. It is less than 5% of all the acute back pain which comes to you. Okay, it's very extremely rare. And among them, 4% is osteoporotic fracture in an elderly, 80-year-old who had a small fall and then comes with acute back pain. So when you have somebody who come to you who is very young or very old, sudden onset of back pain, it is not normal back pain. You have to be very careful. It might be a red flag we are looking at. Okay, but somebody who has back pain for years and then suddenly comes with an acute back pain, that is probably not a red flag. Okay. Now, there are various criteria of red flags, but there's nothing scientific about it. It's all a lot of expert opinion. So the commonest red flags are vertebral compression fracture, old age trauma, steroid use, abrasion, or contusion, okay, ankylosing spondylitis, inflammation of spine, cancer, you guys would be very familiar with that, infection, and cauda equina. Cauda equina is a thing which everyone is worried about. Okay. Now, as I said, all of these red flags, they have very poor likelihood ratio. That means if you have these symptoms, that doesn't mean that they will have a red flag. But when you combine all of them, there is a high likelihood ratio. But on its own, each of these would not have a good likelihood ratio. But one of the useful red flag is a history of cancer. Somebody with a cancer, especially in the last 5 years, then have a sudden onset of back pain, then you have to be very careful. Are we dealing with the recurrence? Okay. Now, the next step is dictated by the diagnosis. Okay. So if it is cauda equina or rapidly progressing neurological deficit, you should have an emergency MRI, an emergency spinal surgery referral. Okay. Now, impending cauda equina, when you have urinary disturbance, altered perianal genital sensation, reduced anal tone squeeze, major motor radiculopathy, suspected spinal infection. These are all things which we should be very worried about. And depending on other situation, you might have to refer to the oncologist or rheumatologist or infectious disease specialist. Now, I'll give you a couple of cases of red flags because I'm just finding that we are not very certain about the red flags here. Now, this is a patient who was in UK, 35-year-old man. Is a very famous patient. Came in media. Fit and well chap. He had a sudden low back pain on just getting up from the toilet. Then he called 999, that's emergency service. They gave him diclofenac, and the paramedics, the ambulance arrives 12 hours later. And this is what his MRI looks like. You can see a huge disc bulge at L4-5, and the transverse section is compressing on the cords. Okay. And what happened was that this chap went on to, because it was a delayed presentation, he went on to have complete paraplegia, and he sued the trust, and he got something like millions of pounds in damage. But the next one is, this is somebody I saw when I was in India. So it's a 40-year-old senior manager, very high paying job. And this guy went to a place in Calicut for a new surgery, keyhole surgery, for a disc prolapse. And that surgeon has just started this thing. And normally this surgery takes 30 minutes, but for him, it took around 3 or 4 hours. And then he was okay for one week. And after that, his pain started worsening. Then he started getting fever, rigor, and this is what his MRI shows. So this is basically a discitis, okay? And his career was over. He couldn't. His whole life was in tatters, basically. Now, if you want to have more information about all these things, there is something called UK NHS spinal pathway. This is a screenshot of that. You can go through it. It's a 100-page PDF file. You can go through that. Now, let's go to the case 2. Okay. Now, this is a 55-year-old female. She's a manager in an IT firm. Sudden intense back pain after lifting 5 kilo weight at work. 1 day duration. Severe stabbing pain and spasm. Worsens with minimal movement. There was some radiation of pain into both thighs, and she felt her legs were going very weak. Okay? She felt as if she's collapsing. Now, when you go back to the past history, chronic low back pain with episodic flare-ups. This is not the first time she's having it. She has got a history of lymphoma completed 7 years back, And on top of that, she's got a lot of other pain problems, migraine, IBS, TMJ, all those things. Multiple specialists went through her, 2 similar episodes in the past, and last was 2 months back, and MRIs, multiple MRIs. And this is what her MRI looks like. Okay. Basically, what's called a type 1 modic change. Okay. So this is what she had. She had some painkillers, admitted, traction, absolute bed rest for 3 weeks, lots of Ayurveda, physiotherapy. Sorry, I couldn't get the pain chart of her. Anyway, so when you look at her, she is walking with a very antalgic gait. That means she's having intense pain. That's what it basically means. And she's got, when you examine her, she's tender everywhere. You say, we say here, even the air around her back is tender. It's not just her back, the air around her back is tender. Okay, and the sensory motor examination is almost normal. Now, what would you do for this? Quickly, some answers, please. What would you do if this patient comes to you? Let's see some answers in the chat box, please. So would you do an urgent MRI, urgent X-ray, or admit the patient, give them bed rest, refer to neurosurgeon, or send the patient home with painkillers and advice to stay active?
I think here we have mixed responses in the chat on most of the options.
Okay. Okay, that's good. So we are making progress. Okay, that's good. So whoever chose E, good job. So the answer is E. Okay. This is E. So this is a lady who, as Vineetha was explaining in multiple slides, she's got what's called central sensitization pain, the nociplastic pain. Okay. Now, as we go back here, she will come in the second step. Okay, yellow flags, all these yellow flags. Now, what are the yellow flags? So patients who have fear avoidance behavior, they think that if I do exercise, if I move my spine, the spine will crumble, and catastrophizing. They believe that there is something serious like cancer. So this lady had lymphoma in the past. Every time she has a pain, she must be thinking, okay, this is a lymphoma coming back. And over-reliance on, okay, so like analgesics, surgery, massage, Ayurveda, all those things. And sometimes it is iatrogenic. We doctors have to blame. Because sometimes we as doctors would look up at MRI and say, oh, you need bed rest. Okay, your spine is degenerating. Degeneration itself carries a very pejorative term. The patients will go home thinking that their spine is cracking like an eggshell, so they shouldn't exercise. Okay, and every time they exercise, they get pain. They think, oh, this is my spine getting more degenerated, so it's better not to exercise. Okay, and depression, anxiety, of course. Now, as Vineetha said, pain cycle, you have to break the pain cycle at some point before the patient improves. Otherwise, she's going to have this pain for the rest of her life. Now, when to scan? So the simple rule is that do not scan routinely anybody if that scan is not going to change their management. Okay, if they are having say back pain, which is being there once or twice every year, and they come to you with another episode of back pain, you don't need to scan them. If you, even after this back scan, your management is going to be the same thing. Okay, and there's multiple studies, as Vineetha said, multiple studies which shows an MRI is not useful for axial lobe back pain. Okay, so this is a study which shows that all these changes on the left side, which are degeneration, desiccation, loss of height, bullet, and these are all present in these are all normal patients. At every age group, they are all present. Even at less than 55 years, this degeneration is present in 77% of the patient. Disc bulge is present in 45%. So these are all basically age-related changes. Like when you become old, you lose your hair, you become gray hair. So all those changes also happen to your spine. So these are all age-related changes. Don't get too excited about these changes. Okay. But then the question is, when the patient is in front of you, you might think, but how do I know if those changes are new or pre-existing? Okay. So they have done multiple studies. They have done multiple studies, and those studies have shown that it is not useful, even in this situation. Yes, as I said, these are the age-related changes. These are all changes which everybody would have. So anterior lateral body osteophytes, T2 signal loss, narrowing of disc bulge protrusion, facet joint arthrosis. Okay. So MRI is not a treatment modality; it's just an investigation. Now, it doesn't improve outcome also. If you might think you will just do an MRI to reassure the patient. What happens is that usually after the MRI, patient come back with more anxiety, more worried about the pain. Now, case 3, let's go to the case 3 now. The 55-year-old male is fit and well, low back pain and leg pain for past 4 weeks. It started after a day of gardening. Sharp stabbing pain, which extends from the gluteal area and spreads along the back of the thigh and calf to the foot. Pain worsens on walking, turning in the bed, associated numbness in the left leg, no weakness, no bowel or bladder symptoms, significant past history of smoking, renal cell carcinoma 10 years back. He's not able to wait beer. He was admitted under orthopedic. Systemic examination is normal. Got reduced sensation over AS1, dermatome territory, that's basically lateral foot, and motor examination is kind of normal. SLR is positive. Crossed SLR is basically SLR on the opposite leg is positive. And this is what his MRI looks like. There is a disc extrusion at L5S1, and this is the disc which is pressing on left AS1 nerve root. Okay. Now the patient was advised surgery. Patient didn't want surgery. They given some medications to take home, antineuropathics and opioids. Given some traction physiotherapy. He was discharged home. Come back if he develops any cauda syndrome. So he had tramadol, pregabalin, thiopurticide, norepinephrine, diclofenac. Pain persisted, and on top of that, the medications was causing him sedation. He was sleeping most of the time, and pain recurred. He's not able to mobilize, but again, no bowel or bladder problems. What would you do in this patient? Let's have another set of answers in the chat box, please. In this question, there is no right and wrong answer, but the best answer I would say is epidural steroid injection. Okay, why? So in this situation, you don't need an emergency neurosurgery. Neurosurgery, all said and done, carries its own set of risks. You only need to take out the disc if it is causing impending nerve damage, like say damage to the cauda equina or damage to say nerve root. Okay, even if there is an impending damage to nerve root in the West, in UK, you won't get a surgery. Okay, physiotherapy, it's all done. I mean, how much more physiotherapy can do in this acute situation? He's basically struggling. Now, number 3, I mean, he's done all those things. He's not fibromyalgia. There's no, I mean, he has got some problems associated with the pain, but that can all be related to the pain. Okay? So he went on to have an epidural. So this is epidural. and he has good pain relief. So basically, the epidural is therapeutic for him. So in this patient, we now come to the step 3, and what he has is a somatic pain. Okay, sorry, a neuropathic pain, and he tried anti-neuropathics. It didn't work. Then he went for interventions. So, but when you're dealing with this pain, there is a small thing which you have to be concerned about, because when you're dealing with sciatica or radicular pain, you have to differentiate it from referred pain. Referred pain is basically somatic pain, but radicular pain is neuropathic pain. How do you do that? Well, because this is an important thing in your, because when you're sitting in chronic pain clinic, most of these patients who come to us, all those first 2 steps have been ruled out. Red flags has been ruled out because most of them have MRI, so red flags is ruled out. The yellow flags is most of the time ruled out because they would have gone through all those primary steps. They would have seen a physiotherapist, psychologist, all those things, and they come to us. In a chronic pain clinic, day-to-day clinic, our job mainly is to find out if it is a referred pain or radicular pain. Treatment thereon would be entirely different. Because the radicular pain, you might benefit from epidural, but for a referred pain or a somatic pain, you might need another set of interventions. Okay. And this is an important step, as I said, and to determine the further management. And this is basically done from the history and contribution from the clinical examination. So referred pain arises, the pain which arises, it is like you have heart attack, you have referred pain to the upper limb, left upper limb. The same way, pain from the joints in the back, like facet joints and sacroiliac joint, they refer to the leg. But radicular pain is basically neuropathic pain because of irritation of the nerve root. Okay, so these are the differences. So the neurophysiology behind referred pain is basically convergence. It's the same for every referred pain, including cardiac referred pain, gallbladder referred pain, everything's the same. A quick slides on when to consider epidural. So epidural should be considered for any severe radicular pain in a prolapse intervertebral disc for symptom control. Because all said and done, the natural history of a prolapsed epidural disc is most of the time to resolve by itself. So this epidural is aimed to manage that symptoms until the macrophages in the body come and take and engulf those prolapsed intervertebral disc segments. So this is basically, and then you need to have a patient who is up and mobile during that time so that they don't get deconditioned. And so these are the indications for severe radicular pain in prolapse disc early in the clinical course. And to avoid surgery, there were studies which shows patients who are waiting for surgery in the West, they don't get neurosurgery or orthopedic surgery on the day they come to the hospital. They go on a waiting list, they might get surgery 1 year later. And they have done studies on patients who were on this waiting list. They send them for epidural steroid injection, and guess what? 80 to 90% of the patients never needed a surgery. The patients who are unfit for surgery because of the reasons. And there might be a situation where there are 3 or 4 discs, surgeons don't know which disc to take. You do an epidural and see which one works. Okay. And some patients can't take anti-neuropathic medications because of obvious reasons. And we'll just go to the next one. So the thing about epidural is that you have to give it as early as possible. It is almost like a fracture. If you have a fracture, you don't wait until the fracture heals by itself before we fix the fracture. In the same way, you don't wait until the disc prolapse resolved by itself before we consider epidural. You have to give it as early as possible. The advantages are it avoids the problems of medication, surgery sparing, and it avoids central sensitization, because the more you leave the patient in severe pain, the more that the pain is going to become widespread. As I said, it is natural history's resolution, and early epidural can help in effective pain relief, avoid side effects of medication, surgery sparing, and avoid central. Now, you might be wondering, are spine injections safe? So this study from Mayo recently showed 26,000 patients, follow guidelines. There was hardly any complication. There was complication rate was 1.9, and these complications are simple complications like vasovagal, no serious complications. Okay, so when evidence-based guidelines are observed, complications is nil. Okay? Now you might wonder, but steroid use in interventional procedure, will it cause osteoporosis? In fact, this study shows that in fact it reduces the risk of osteoporotic fracture, because when you give steroid for this say a disc prolapse, the patient becomes mobile, they start moving, and the best treatment for osteoporosis is mobility. So before I finish, I would like to recommend this book, Understanding Pain. It's by Fernando Cervero. He was a chairman of IASP, and this book gives a good overview, because all said the physiology of pain is very complicated, and this book gives it in a very kind of a novel, as if you're reading a novel. So if you have not read this, it is available in, I have it still with me. I have read it 3 or 4 times. It gives you a greater overview of what chronic pain is. That will change your perspective about chronic pain. So as summary, always have the patient in the center of decision making. Believe the patient, okay? Don't prejudge the patient that they're faking it or it is a functional pain. Okay? There are situations they might fake it, but it is extremely rare, especially in a situation like in India, where there is no secondary gains to be had from faking pain. Careful pain assessment is paramount. You have to diagnose the type, site, and cause. Not every pain is the same. You have to spend some time. This is only one of the few areas in medicine which is left, which needs your clinical examination, hence clinical history taking skills. As I said, there is no scan, no test which can replace clinical examination and history taking in pain. So this calls for your going back to the basics. Okay, optimize medications. You have to give them optimum pain relief, but acceptable side effect. You can't be expected to give them all the pain relief they want, but the patient is completely knocked off. They can't mobilize, they can't think, they're sleepy. Okay, and in the long term, you have to support the self-management of the patient. There's no point in giving them pain relief and then they keep coming back to you over and over again. This has to be a long-term plan in place. Okay? Now, intervention treatments are guided by individual patient-centric characteristics. So it is not that you have a problem in MRI scan, you stick a needle there. No, it has to be guided by the overall patient, what the patient is having, what the benefits of the interventions are, and the patient should understand what they're having. Okay, what are the side effects, what are the pros and cons. Okay, and remember, all the non-cancer pain is not end of life pain. Okay? There's a huge problem. A lot of cancer patients are surviving because of effective cancer pain relief, cancer pain treatments, and chronic pain in cancer pain patients is a huge problem. Thank you. Now, I don't know whether we have time for opioid epidemic. If so, I can devote a couple of slides on that, or else we can go for any questions.
Dr. Ajeeth, I think we can take some questions if there are any. We were supposed to take a case presentation, but probably we may not have time for that. If all the participants agree, I'm okay to take the presentation also quickly. But maybe we'll stick on to any questions and answers from the group probably. Are there any questions? You can type it in the chat or you can unmute and ask the question. I think it's all about your presentation and messages to you, both of you. Dr. Sunil, are you still there?
Yes, sir. Devi.
Yeah, maybe a few words from you, either to conclude.
Okay.
So even though I was unable to attend the session fully, I heard what Vineetha talked maybe after 30 minutes of a session, and rest by Ajeeth. So what what I want to take from this session is that all of us are seeing many patients, most probably patients with malignancy, and we might be or we are experts on that. But when it comes to patients with non-cancer chronic pain, or even in patients with cancer, we have to think that that may not be related to cancer itself. It may be due to something else. So Ajeeth was planning to discuss the opioids also in a role of opioids in non-cancer chronic pain, but we do not have much time. But it is important to understand that the pain treatment with a non-cancer chronic pain, it is not same as that for cancer pain. And we have to think of when we see the patients with chronic non-cancer pain, we have to understand what is the pain generator. And Vineetha and Ajeeth have beautifully described what all can be the pain generator. And it is also keep in our mind that what are the red flags. So if we see some patients with red flags, then we have to be careful, and probably we need to refer to somebody else. And in addition to red flags, there are some yellow flags also. So these are some points which we need to understand. And if there are red flags and yellow flags, we have to be careful. And after that, we doesn't we will come on to the nociceptive neuropathic and neuroplastic pain. So it is mostly regarding the awareness on how to treat non-chronic chronic non-cancer pain, and what all we should be careful while we looking the patients with chronic non-cancer pain is important. So
I think there was a question, Dr. Ajeeth answered the question on steroid, and Dr. Prakar has also mentioned that finding out the cause for pain can sometimes actually delay and more agony to the patients, maybe.
No, that is true if you're dealing with acute pain. So somebody comes with, say, acute fracture, you don't, or say acute disc prolapse, you don't spend a lot of time trying to find out the cause of the pain. You have to do the primary things, give them adequate pain relief. But if somebody has this back pain for 20 years, it won't help if you just focus on pain relief, because that's what happened in US. They in 1980s and 90s, they spent their effort in curing pain, basically curing pain at any cost. They started prescribing opioids for patients who come to the general practitioners with headache, back pain, and then they started hooking them on opioids like oxycodone, without knowing what the pain is, whether it is a pain from a disc prolapse which can be treated, or whether it's a nociplastic pain, whether the patient's pain underlies severe depression, anxiety. And imagine if you put opioids, you start opioids on somebody who is depressed and anxious, the worst combination possible. So you're right, it might cost time when in an acute scenario, but in a chronic pain scenario, it's better to find out why the patient is having the pain before you start treating it.
Thank you, thank you, Dr. Ajeeth. There are no more questions in the chat. I would like to mention Dr. Rakesh has come up with a wonderful case presentation, but we couldn't take it. I assure Dr. Rakesh we'll go through the presentation, and we'll take some opinion from the faculties today and get back to you with some answers from their side, if that is okay for you. Thank you so much for bringing up a presentation for today. And my apologies for being unable to take it for active discussion.
It's okay, madam. Okay. It's okay.
Thank you so much, all the participants. Thank you so much, Dr. Vineetha and Dr. Ajeeth, for once more doing this session, Dr. Ajeeth from UK. It was very insightful, as Dr. Sunil said. Thank you so much from our team. We'll see you all next week with another topic. Rajlakshmi.